Okay, hello everybody. Welcome to today's Network Mind Out online panel discussion. Thank you for everyone for joining us. This is actually the first time we've done a panel discussion, so we'll be quite interested in hearing back from people whether you like this format or whether it works okay for people. My name's Sally Morris. I'm from the National Lgbti Health Alliance with the Mind Out project. And today, we've actually got three guests who's going to be talking with us on the panel. But before I introduce them, just like to acknowledge the traditional owners on the land on which we're gathering. And because we're online and meeting from across Australia, we are on lots and lots of different types of lands today. So just really acknowledging that. And I just want to double check that before we really kick off, that people can actually see and hear us. So on the platform, on your lower left-hand side of your screen, there's a little chat box, and that's how you can communicate with us. So if you can see and hear us okay, can you just type us a little message to say that all okay? Thanks, Ross. Excellent. Thank you very much. If throughout today, if you have any problems with sound or audio or anything along those lines, please just type us a message there. Just help us to let us know if there's any problems. So I'm just going to introduce today's panel to you, but also today's panel was also quite interested in knowing who is in today's webinar. So also in that little text box, if you want to type, we invite you to type a little bit about just your area of work that you work in, so whether you're a social worker, a psychologist, a youth worker, and whether you have an area of interest. For example, if you're interested in young people, older people, people with disabilities, for example. It can just sort of help them when responding to questions to know who's listening today. Okay, so just to introduce, I'm going to start with Kristen Davies. So Kristen Davies is a research associate in the discipline of child and adolescent health at Sydney Medical School, University of Sydney. Her areas of expertise are relevant to this panel include gendered and sexual subjectivities and citizenship, constructions of childhood and youth, sex education, health and wellbeing, including HPV and HPV vaccinations, sociology of medicine, gendered and homophobic violence, and innovative pedagogies and educational practice. Kristen has been published widely across disciplines of medicine, health, education, gender and sexuality studies. So welcome, Kristen. I'm going to move to the bottom of the screen and introduce Dr. Jude Comfort. So Dr. Jude Comfort is an experienced public health academic with an academic background firmly based in practical health promotion skills base. She runs her own public health consultancy and holds an adjunct position with the Collaborative for Evidence Research and Impact for Public Health and the School of Public Health at Curtin University in Perth. She has a long background in public health practice and advocacy, particularly in health equity and LGBTI health issues. Research areas include cancer prevention, legal drug use, Asian issues and LGBTI health, and wellbeing and inclusive practices. She has a strong interest in advocacy and public policy that promotes health equity, which is informed by social determinants of health philosophy. And we also have Atari Metcalfe. So Atari brings over a decade of experience in health promotion, research policy and strategy, specialising in e-health services, youth health and suicide prevention. He's a former board director of Suicide Prevention Australia and has worked in senior research roles at Reach Out Australia and an analyst to national inquiries to asylum seekers, transgender, intersex health and human rights for the Australian Human Rights Commission. Atari also helped establish Western Australia's first transgender youth peer support and advocacy group between 2002-2006, and later served as a co-chair of 2010 Incorporating GLCS, where he remains a board director. Atari is currently studying a graduate medicine with the goal of continuing to promote human rights and health as a future as a medical doctor. So thank you to everyone for joining us here. So how today is going to work, I'm going to host today and ask the panel some questions, and they're going to respond based on their experience and knowledge and expertise in that area. So I actually might start with Atari. If you would be able to really interested in your reflections about the the historical experiences of LGBTI inclusion in mental health and suicide prevention strategy and your connections with that.
Sure, thanks, Sally, and hello everyone. It's nice to see so many interesting people on the chat box and lots of people representing all sorts of parts of Australia. So yeah, I guess in terms of reflecting on inclusion of LGBTI populations in mental health and suicide prevention, my experience in that is sort of mostly at a policy level. So just to qualify the context I'm coming from, it's changed quite dramatically in some ways and then seems to be sort of stagnant in others. So thinking back over our first ever suicide prevention strategy in Australia in the late 90s, there was some inclusion of LGBTI communities in the Here for Life funding, for example, which helped establish the Freedom Centre, which is a peer support service in Western Australia. And subsequently, there were a number of other mentions of LGBTI, although I should probably clarify that and say same-sex attracted groups as being at high risk, but always with caveats. So for example, the early plans would make reference to the group being at high risk, but there was always a limit to the extent that they would describe that risk. So by that I would mean, for example, they would say same-sex attracted young men and same-sex attracted young women appear to exhibit higher prevalence of suicidal behaviour, but to this end, we are not sure whether this is represented in suicide deaths. And that was largely and still remains the case because that we didn't have the data around mortality. And so that sort of set up a bit of a, is it really a problem dialogue in policy circles, which was very problematic. But that shifted in the sort of mid to late 2000s, and particularly when we had the big Senate inquiry here in Australia. So that was 2009, 2010. The large Senate inquiry into suicide in Australia. And by that point, we gathered a little bit more evidence about just how big the problem is affecting these communities, and certainly started to broaden the discussion from just same-sex attraction to also consider the impacts on people who are gender diverse. We hadn't yet got there, I think, in acknowledging intersex people and the struggles they face, but certainly we had more evidence that, particularly from, say, Queensland and other data sets internationally, that unfortunately, our suspicions were correct that those suicidal behaviours were translating to higher rates of death in those communities compared to the general population. And that, I think, spurred some significant action from the government at the time. They released a really large report which dedicated quite a bit of content to the need for action in LGBTI communities, and they specifically spoke to themes around access to care, inclusion of services, but some might argue it didn't quite go far enough because it sort of spoke to the group as one community, when what we know, of course, is that LGBTI people and peoples are many diverse communities with different needs. So in some ways, we've made a lot of steps forward. There is now some inclusion, and following that Senate inquiry, there was significant funding made available too, including the funding to establish MindOut, with which we're kind of participating today. And there were subsequent state and territory equivalents. So the Victorian government, for example, have provided significant funding for youth suicide prevention in the LGBTI space through the HAY program, and I believe there are a number of similar initiatives in other states and territories. So there seems to be a bit more backing now and resourcing. But I guess the frustration is that it is kind of inconsistent and it's not well coordinated. But I won't get too much into the challenges. I'm probably said enough. But it certainly shifted from a place where there was maybe not really acknowledgement that there was a problem to now, yes, there is a problem. But we're yet to, I think, grasp the full etiology and by extension know the best way to tackle it. And that's certainly lacking in the plans. So that's sort of my initial thoughts. For the others years as well.
Great, thank you very much, Atari. Actually, Jude, I'm quite interested. I know you work in the more LGBTI aging and aged care space and have had a bit more involvement around the development and implementation of the National LGBTI aging and aged care strategy. Do you sort of feel that there's links between what's happening in the aging and aged care space and what we're currently or have been seeing in the mental health space, or are there still big gaps between those two?
Look, I think, like Atari said, I think we've made some inroads, and I think there are some parallels with the process that we have been through with the ageing and aged care strategy. And the first of those is really to start to look to have a solid evidence base. And without that, I think it's very hard pushed to move forward. And that's really what kicked off the big changes in the aged care environment. We were just very lucky that all the stars aligned, that the Productivity Commission had been asked to look at the aged care sector. We jumped in, and I say we, there is a strong collaboration in different states working in the aged care, Lgbti aged care area. And I think the work that's come out of that all shows the strength of working together. And I think that's something we can definitely learn from and take forward to the mental health space. So I guess my quick thoughts are we need to have an evidence base, and Atari's already hinted that that's not very complete. There's also complexities in collecting LGBTI data. I think the next thing is that too often we just lump LGBTI issues all together. It's a very diverse, it's a very unwieldy alliance in a way. So we need to understand that. And my final point in reference to how we've gone forward with aged care, and I think some of the lessons learned, is we need to bring the sector along with us. And when I say the sector, I mean the broad brush of everybody involved in mental health, not just LGBTI people, because we've done a lot of training with that broad professional development for people working in the aged care area. And I would really caution people to don't think that everybody understands LGBTI issues. We've got a lot of professional development to do out there if we're going to see things move forward. So that's just a couple of points that we could learn from.
Thank you, Jude. Actually, Kristen, that actually sort of leads on quite well to you, because actually your area has really been a lot of research, and certainly in the LGBTI youth area. Did you want to reflect upon what's sort of happening in that space and how that is really contributing to what we do know or don't know at the moment?
Sure. So I can talk about a couple of recent projects that I'm involved in or know about, and this is of course building on the work of other people, which I know quite a bit of history, some of that research as well. A couple of studies. So the Growing Up Queer study, which was building on writing themselves in, all those studies as well. So we've just been doing some deeper mining of that data. So we had found that 41% of young people had thought about self-harm or suicide, 33% had harmed themselves, and 16% had attempted suicide with gender diverse. I found out that feeling safe at school decreased rates of actual by 50%. And that safe at school.
Sorry, Kristen, I'm just going to interrupt. Can I just ask you to speak up a little bit louder? We're just having a bit of difficulty hearing.
Need me to repeat any of that, or?
The last sentence we dropped out.
Okay, so we just have done some extra mining of that data, and we found that feeling safe at school decreased rates of actual self-harm by 50%. And in addition, that feeling safe at school decreased participants' attempted suicide by 58%. So, I mean, we're working in a difficult political climate, but it just shows how important the correlation between feeling safe, and I've just highlighted at school because they were the most prominent statistics, but feeling safe at home, in the home environment, and also in social spaces, but primarily at school is the one that stood out, certainly for people. So that's from the Growing Up Queer study. There's also been another study that's been released called You Learn From Each Other, LGBTIQ Young People's Mental Health, Help Seeking, and the RAD Australia online database. And that's a collaboration between 2010 and the Freedom Centre and Curtin University and Western Sydney University, so researchers across all of those spaces. And they, or that report has highlighted the value of peer networks for support, referral, and understanding of issues. And therefore, they have developed a website that whereby young people can say, I've seen this physician or this psychologist or that social worker, and they actually recommend individuals and organisations, because this is what young people in particular really, they and like other studies, the most young people in need were gender diverse people and intersex. Another study going on at the moment at Sydney Access Group, led by Melissa Kane and Robart. That's exploring how marginalised young people navigate the health system. So it actually has many streams of young people, Aboriginal.
Kristen, we've just lost you again. Sorry, I'm going to have to ask you to speak up again. Come in closer, please.
Gender and sexuality diverse people as well. And actually gender and sexuality diverse young people in our preliminary results are the most at risk, psychological risk out of that subgroup. And of course, I guess the important thing to mention is the intersectionality between gender and sexuality diversity and, for example, Aboriginality or having a disability and so forth. I hope you were able to catch those.
Yeah, we caught most of that. Atari.
Yeah, I was just actually just going to recommend to Kristen that if she's using her computer microphone to keep your voice directed towards the computer. But yeah, I completely agree with what Kristen raised, and those intersections are really important, and it kind of speaks to the point that Jude made before about the risk in lumping together Lgbti as one group and failing to recognise that there are other aspects to people's lived experience that may place them at greater risk, including cultural and ethnic background, economic background, rurality. Suicide is a complex and multifaceted problem, and it's tempting to attribute all variance in suicide risk to one particular attribute of a person's experience, and it's often a product of multiple things. And the I suppose good news about that, the inverse, is that often the protective factors play a huge role and can be quite significant in the contribution they can make. So the point Kristen raised about feeling safe at school, it's again been reinforced by Lynn Hillier's work and those the writing themselves in studies. They found similar correlations when they cut suicidal ideation attempts by experiences at school and feeling supported by different people in young people's lives. And I think sometimes we focus a lot on describing the problem without maybe emphasising what we know seems to point to protection. And I think that certainly safe and inclusive environments are key. Interestingly, the stuff about accessing to care, we know well, some of the data, I haven't yet published this, but from Reach Out, we did a large study of over 2,000 young people who, many of whom were experiencing quite acute and complex mental health problems. And about 700 to 800 of those young people identified as LGBTI in some capacity or a combination of, which places them at about 30% of the sample. So for starters, that's huge, that there's a huge disproportionate number of young people who are accessing a mainstream service, albeit an online one, and I think that's an important point I'll come back to. But what was interesting in that data is many of them had already accessed some type of care, a medical doctor, a psychologist, a social worker, and in fact at rates that were higher through multivariate regressions. So once controlling for everything else, people who were same-sex attracted or gender diverse or intersex or a combination thereof were more likely to have accessed care than their peers. That doesn't necessarily confer better health. They still have far worse outcomes. And there's a question that, and this is a parallel, I suppose, with Aboriginal health here, where more care doesn't always translate to better outcomes. And I think it gets back to that etiology of the safe environment, social determinants. And it's part of the solution in terms of making care more accessible and certainly more appropriate. We certainly don't know whether the care that they experienced was actually good care or maybe quite negative experiences, but it's really important, I think, to work across the spectrum. And in suicide prevention, we can sometimes get, I think, very caught up in downstream interventions when we just step back and think about why people feeling like ending their life is front of mind in the first place. And yeah, I think there's some hints in the data at maybe some of the contributing factors, and certainly one that's very rarely addressed in suicide prevention strategies, not just for LGBTI people, but general populations that we know plays a huge role in suicide prevention, is alcohol and other drug use, for example, is one determinant that we seldom address. So there are intersections too with other areas of health policy that we need to know.
Awesome. Thank you, Atari. Actually, I'm sort of curious about, so we talked a bit about research at the moment, about what is the link between research and policy? Why is research important to policy? Maybe Kristen, can I put that to you first?
Yeah, sure. I think both Jude and Atari have mentioned the importance of a sound evidence base to underpin policy, so that we know that that policy is on the mark as well. And I think having that strong evidence base is really important. But certainly in terms of the strategy, that why we're actually here to talk about that today, I think that it would be really great for individuals and organisations who are listening today to actually think about how we're going to implement this strategy. And I think that's very difficult. And I would highly recommend that people, if you're coming from a particular organisation, have a look at your strategy or your values or your ethics, or depending on what context you're coming from, and to actually start mapping, how your strategy might fit in with the prevention strategy that we're talking about today, and to actually map that out as part of, for example, a 3-year plan. Because I think what will be really important is to try and measure the effectiveness and success, if you like, of putting this strategy into practice. Because often, strategies, you go into people's, GPs and whatever, and they're kind of sitting on the table, and you're thinking, well, how is this being translated into practice? So I think the importance of research to underpin policy is to build a sound evidence base, so that that policy makes sense. But then the policy is there, and that's all wonderful and great, but we actually need to be able to implement that. And this takes a considerable time and thinking to actually to map this out in a way that we can actually measure it and see the effectiveness of a strategy working with a city.
Great, thank you, Kristen. Actually, Jude, I'm sort of also, I know this is an area that you're really interested in, about inclusive practice and putting strategies into practice.
Well, just a couple of points. First of all, I would really urge people to also come from a perspective of saying that many LGBTI people live healthy and happy lives. So let's not pathologise this group. I think there's a real danger when a group is overrepresented in the statistics to pathologise them. I think Atari's hinted at it's way more complex than just saying you're LGBTI. So that's one point. The second thing is about evidence, where evidence sits. I think, first of all, we need some basic prevalence data if we possibly can, because although we in the room are probably very aware of the situation and the overrepresentation in statistics, we also have to convince the people who hold the purse strings and the people who are going to hopefully fund our project. So in the first instance, I think we need to be really realistic about, can we collect some data that will convince the powers that be. So that's been very strategic in the sort of information that we want. And I guess for me, then the second type of data and research, which Kristen has hinted at, is the evaluation of what we do. We don't want to be putting money into projects that don't work. We want to, I think, be working from an evidence base, because that is really going to be the way forward. And that therefore puts out the plea to anybody doing service delivery to think about how you can capture some of that, report what you're doing, whether it works or not. We also need to be upfront about things that aren't working, so we can learn from that. And so I guess that leads on to the next part of your question, which is, yes, we probably have to upskill our workforce. And that upskilling is about getting people in the workforce competent and confident about working in the LGBTI space, but also in some of those other tools that we want to use, like evaluation practice. And how do you collect that? There's some really good little tricks to the trade. I'm not talking about doing PhDs on that, although that would be fabulous. But doing some grassroots evaluation that we can then share with other people so that we're not reinventing the wheel, and we can build a community of practice and start to learn from each other. I'm not sure if that answers the question, but that's a few points I wanted to get across.
No, thank you very much, Jude. There's just so much wisdom here on the panel, and actually what we would like to do is, if any of the participants would like to issue a question to the panel, please feel free to do so via the text box below. If there's someone in particular you'd like to direct that question to, please just let me know in that little message and I'll field those and pass them on to the right person. But while we're waiting for any questions to come through, Atari, I'm sort of also interested, I guess, because you've really spent a bit of time in that sort of advocacy policy space, and obviously we're around when the Hidden Toll report came out, and which really helped spark this greater inclusion of LGBTI people in a national policy space. I'm curious about what you think are still the gaps. Where do we still need to achieve further inclusion, and what are some opportunities that you think might be there for that?
Sure. Well, I guess, there was some really positive outcomes from that Hidden Toll inquiry. I think it helped create a sort of zeitgeist of sorts, especially amongst mainstream services. So Beyond Blue, Headspace, Mental Health Council Australia, all of them got on board and started to see that it wasn't just the work of LGBTI communities themselves to have to address this issue, and that they all have a role to play, which is fantastic. Certainly, I think the gaps still fall into, I mean, we kind of talked about some of them around, we think we know a lot about it, and we do know a little bit about it. We don't know exactly, I think, what is most effective practice when it comes to preventing suicide for these communities. So I'm coming back to the evidence-based theme, which we've just heard about as a major gap. And that's sort of challenging too. There are some structural barriers to that when a lot of at least the government-funded initiatives don't really resource evaluation, or the kind of evaluation they resource is activity-based metrics rather than pattern outcome-oriented. But in terms of gaps, in terms of strategy, I think I mentioned before, I think the links to things like alcohol and other drugs and the intersections with, I think, looking outside of the health system, which is a really tricky thing to get the health bureaucrats to think about. It's not something I think that can be solved from within the health system. And there's a lot of resistance to this, and we've seen this with the Safer Schools initiative recently. I think trying to get other sectors on board to see their role as central to the well-being of this community and is always challenging, but when it's layered with the political charge that LGBTI needs often bring from particularly conservative elements, it's really hard. So I'm not offering a solution there, but I think we need to continue to work on that space. I think the biggest bang for buck will be in these non-health domains like schools and community settings, and really moving towards a society that actually affirms and values people in all of our diverse ways. So that still remains a challenge, and certainly, the need is outstripping the ability to meet those needs at the moment. I guess in terms of policy and what works, having allies and a coordinated voice. I think we heard a little bit about the stars aligning from Jude in terms of aged care. It's the same principle. You get these little windows in policy worlds where there seems to be a coalescence around an issue, and you've got to strike while that's hot. And that is tricky when you've got minimal resources to bring to the table. But certainly working, I think, across multiple sectors and multiple players with a shared voice. And in fact, the Senate inquiry sort of did that to some degree. Suicide Prevention Australia commissioned a big paper on the current evidence around suicide prevention and in LGBTI communities in 2009. And it was just really well timed, and it was an accident. It happened 6 months before the Senate inquiry, and it happened to just pull together. I was the author of that paper, but I didn't invent any of the research. I just pulled together the research of many others before me, from John Howard and John Nicholas and Graham Brown and others in the 90s through to the point of that paper being written, including the writing themselves in private lives, and there's been a series of studies, and then also digging through the national data. And so the bureaucrats had seen that data before, but they hadn't seen it in one place. And that place, by bringing that one document together, gave other organisations a point of which they could reference, and then they were able to put their lens on it. So we had a sort of, it wasn't just that document, it's a group of many, many people singing together and saying this is what we need to do at the same time. So I think that's part of the art and science of the policy window. You need sort of the evidence base at the ready, and then to coordinate a bit of a shared agenda is sort of key. And obviously having sympathetic people in Parliament we have a relationship with is also important. And that Senate committee, it was cross-party, but the representatives were all very, I think, sympathetic to the issues that they were hearing. So that was very fortunate. Not sure if that really answered your question. Sorry, Sally.
Yes, yeah, no, that was really good. We do have a question, but before I get to that question over on the comment box, I'd actually, Kristen, I'd like you to, I know that you really have an interest in about that how policy really needs to link to what we do in practice and translating knowledge from policy to practice. Did you want to reflect a little bit about what your interest is in that?
So I've got my, I'm looking at the question at the same time, but I was thinking about when Atari and Jude have been speaking, Jude said something really important, which was to build a community of practice, which I think is really critical. And I actually think that something like what we're doing today is perhaps beginning to do that kind of, the Health Alliance has already done a lot of work, so I would encourage us to be a part of that, to continue with that, because I think it's really critical. And another thing is, I guess, the importance of interagencies. So, you know, for example, health regularly works with education, and there are some agencies there because funding and policy works in different ways, but often there's duplication. And so I think it's good to be part of those interagencies. Advisory boards and so part of that agency.
Sorry, Kristen, you're dropping out again. Sorry.
Community of practice. Were you able to hear most of that?
Yes, that last sentence dropped out again.
About, I guess, the importance of communities of practice, which is what Jude had mentioned, the importance of interagencies, like, for example, health and education working together, and then also to have community members and organisations as a part of that, so that the voices from those communities are actually being represented. I know that the Health Alliance is very good at facilitating and enabling those sorts of practices. So sorry, I hope you can hear me. But I've also got, while I'm here, a response to the person who's posed a question there, just from the Growing Up Queer research that we did. One of the really interesting things was that most young people who do access help organisations, and it's generally the organisations that are kind of advertised in the media. So lots of Lgbti people, for example, call Kids Helpline, or Beyond Blue, and perhaps Reach Out as well, Atari Online. And often those larger organisations refer young people on, should they say anything about their gender or sexuality diversity, to organisations like 2010 or the Freedom Centre and other similar organisations to place. But I guess to health professionals would always be to ask. Young people said they want to be asked. They want to be asked about what pronoun is appropriate. Want to be asked about their gender and sexuality in a primary healthcare consultation. They won't necessarily raise it with you, but that's certainly what young people.
Yeah, and yes, Atari, would you like to respond?
I'd just like to reinforce Kristen's point about asking. The don't ask, don't know is a major issue, and even if a young person isn't experiencing questions or isn't identifying as anything as LGBTI or any other wonderful term that young people use today, it's a beautiful point to teach them, and I think it's an opportunity to educate their peers about the spectrum of diversity that exists in gender and sexuality. So it's certainly no harm in asking. And from a research side too, there has been concern that if you put it into a research project or into your evaluation forms or your intake forms, that there'll be people might feel uncomfortable. It's a sensitive question. I've had ethics committees raise this. We did some non-response bias analysis on studies I've worked on, and we found that young people were more concerned in the context of an anonymous service telling us their postcode than they were telling us their sexuality. So the drop-off at postcode was huge, but not at sexuality. So I just wanted to address that because that's been a resistant barrier I've experienced before. But the question about the risk of people who have not disclosed, that is huge. And the data that I'm about to reference is a bit old, but I haven't yet seen any data to suggest that this has shifted. But certainly the early studies into same-sex attracted young people in suicide found, on average, those who had survived a suicide attempt reported the attempt at the age of about 16.9 years on average. And at that point, and this might have shifted now, but at that point, most young people hadn't disclosed their sexual orientation to anyone else for another 3 odd years. So there is definitely concern that prior to coming out to people is a particularly risky period. And the qualitative data around that statistic that these researchers, which this is John Howard and John Nicholas, their work inquired into, so why is it that there's this risky period? And it was often the fear of rejection. Unfortunately, many people did not have that fear translate into reality. Many of them were actually met with supportive responses. Of course, there are those who are not always so fortunate, but definitely that is an issue. And from a data perspective, that raises all sorts of challenges. We don't therefore know, unlike other attributes, say cultural ethnic background, which are obvious to everyone else because that minority status is shared by their family and community. We don't see that in the suicide data in terms of death statistics. So it is an issue. And for that reason, the data we do have is certainly likely to be an underestimation of the magnitude of the problem. And it is also implicitly a problem in terms of identifying people who might be at risk if they've not told anyone yet. I think that's where sometimes the online services play a huge role. It's sometimes safer for young people or less intimidating to disclose online than to someone face to face, and they can trial different identities and see how it feels without the fear of rejection of the people close to them. So that's an opportunity, I think, for prevention.
Yeah. Thank you, Atari. Jude, I might ask you to reflect. I know that both Kristen and Tari actually have a really strong youth experience and focus, which is often why they defer to that space. But I also know that you work a lot across the age span, the lifespan. And when we've spoken before, you've talked actually sometimes older people can also be at equally at risk of this invisibility and isolation as well. Would you like to reflect a bit on that?
Yes, I would, because I think there's looking at that question, there are certainly lessons to be learnt in the aged care, at the ageing space as well. Because in what we know is that for LGBTI people, there are probably 2 peak periods where mental health issues, suicidality, may be more evident. And one is at that younger stage when people are trying to form their identity and not sure where to go. And then the second stage is later in life, particularly when people may be in that vulnerable space of needing to get some support in their life and some loss of independence. So just a couple of thoughts around that. I think the more often that agencies and service providers meet people halfway, we are so often the people who are always doing the coming out. My experience, both personally and professionally. So as Atari said, if agencies ask the question, even if that person doesn't feel like they feel it's a safe enough space to answer, it is at least giving some clues that LGBTI issues are on the radar. And that's certainly been the case for older folk. And many older folk, we talk about this going back in the closet, because many of them, once they had overcome some of their youth struggles, have gone on to lead fantastic lives, lots of fun, good living, But as they have aged and needing some more support, then they're not sure. They think it's still a hostile world out there. They're not sure how they're going to be received in these services. And so in that case, what I would recommend is that the agency and the service providers have to, and it's not an easy answer to this, but they need to demonstrate that this is a safe LGBTI space. And I guess that's the meeting them halfway. You can't always expect these older people who are already in a vulnerable space that they're going to stick their hand up and say, hey, I'm a part of the LGBTI group. And getting back to the broader range, looking at the social determinants of health, we really need to recognise the historical setting in which somebody in their 80s or 90s has grown up in. And a lot of people say to me, well, isn't all of that fixed now? Look at young people. Why is there such an issue? Well, obviously it's not fixed. We live in a basically homophobic society still. We might not see those very blatant violent acts, but I would argue that it is very much still a homophobic society when you're talking about the society at large. And the second thing is that for service provision, many of those who don't operate in an exclusive LGBTI space, and there's not very many that do, they operate from a model of heteronormativity. And that basically means people coming through their service door will assume they're heterosexual. And that is one way of really getting people offside. So when I talk about needing professional practice for the whole sector, that is the sort of issues that need to be addressed. My perspective is we need to raise the bar on all service provision to be an inclusive practice. We can't just say, let's leave all the LGBTI people, we can put them with Reach Out or the Freedom Centre or whatnot. Australia is a huge country. So if we just leave service provision with identified LGBTI service providers, then there's going to be huge gaps in the service provision for people who live in remote or even regional areas. So for me, it's about raising the professional bar across all organisations. So don't assume all your clients or people who come to use your service are heterosexual, and think about what the implications are, how you can therefore make a welcoming and inclusive practice.
Thank you, Jude. I might ask this question to each of the panel members one at a time, and I might start with you, Kristen, which is pretty much, I just really interested, I guess, about what's your hopes and vision for the future of LGBTI mental health and suicide prevention. I was just sort of, curious about where you see the sector going. Do you have concerns or worries, or do you have hope? So Kristen, I'll start with you.
All of the above, I think. Concerns and worries, but let's focus on the hope, because I think, that's the best way forward. I think some of the things that we've spoken about today are really important. So in terms of, talking about the strategy, that's what we're talking about today, how we can implement that in our services. We're working in health services across the board, as Jude was talking about. And I also think evaluation is really important as well, so we can see whether or not the practices that we're using to implement a strategy are successful and helpful, and also building on what Jude and Atari have spoken about too, which is to build a community of practice. We don't, so many of us work in silos. I don't think that's very helpful, and it's great to share successful practices, and most of us are kind of aware of the policies, but if we share our practices and the way in which those can be implemented, I think that's really helpful. So it'd be really fantastic if today everyone who was listening went back to their organisation or their context and shared the strategy, and then perhaps thought about how they could implement that strategy and to actually do a plan to that effect. But I would really like to see a lot more money for evaluation in this area, so that we actually know that we're putting into place the practices that are best going to serve the communities that we're talking about.
Great. Atari, can I ask you the same question? What do you see for the future of LGBTI mental health?
Everything Kristen said as well. I would love to see good evaluation data, so that as we do implement these strategies, we can see if we're hitting the mark, and if we're not, how we need to change. I guess by extension, I would like to see some sustainable investment in this space, and the short year-to-year contracts, Department of Health keeping projects on the edge without like proper programmatic funding. This is a long burn issue. Changing views and the core determinants of suicide, whether it's for this community or other communities, takes time, and it's going to require a long-term investment. So I'd like to see a proper investment that is sustainable and gives people time to really implement programs and work with communities to implement those programs, rather than have to shortcut and just put the strategies onto the communities, which is also something that takes time to get people on board with and have them truly participating in designing the right solutions for their particular community. I think we talked before about the gaps, and I'd like to see a greater emphasis on the diversity of LGBTI communities in their state and federal plans and frameworks. I think the document that you, Sally, and Ross and the team at the Alliance have recently launched is a nice template for the government to maybe consider, and they could incorporate some of those, the content of that strategy into their own. And I'd like to see that integration with our National Mental Health Plan and suicide prevention frameworks. I have many more on my wish list, but I guess those are probably the key ones.
Awesome, thank you, Atari. Jude, how about for you?
Well, I'd certainly support the very long list that my colleagues have already mentioned. I would like to see a society that was more inclusive of everybody of diverse sexuality and gender identities, and I think that is a starting. That's got to happen if we're going to see an improvement in mental health and suicide stats. So we've got to look at what the wider society, why there are people who feel they don't fit in, and that's one aspect. I would love to see more sustained resourcing. This is going to cost money. As much as we can go forth and do our own bit, this is a serious issue. It needs to be taken seriously, and governments at all levels need to commit some funding to do that. Agencies also need to take this on board as a serious issue, and that means we've got to have management and senior executive buy-in. We know there's some fantastic LGBTI champions out there who are working within their agency, but unless they have the support of senior management, then it's not a sustainable model. So I'd really ask agencies out there to think about, how are you demonstrating? Do you have a diversity policy? Do you actually spell out LGBTI issues? And just one final thing following up from Atari, I think we need a far more nuanced conversation about the different parts of the LGBTI rainbow. The issues that face parts of that community can be very different. So we need to really understand what is happening. Actually, I've got another final point. Please, can we put some money and resources into workforce development?
Yeah, absolutely. And I agree on all of those points as well. And I think the other thing I'm just going to toss in is a bit of my wish list about what I want to see for the future. I actually really want to see LGBTI populations adequately represented in broad government suicide prevention and mental health strategies. In developing the document that we've just worked on, it was really clear how absent that is. And I guess my hope is that when we have adequate inclusion, those really overarching strategies, that we then will see the development of programs that are more inclusive. We'll see allocation of resources. We'll then see commitment to inclusive practice, and hopefully therefore see more services on the ground, which is really what each of us are here trying to do. So I'm mindful we're coming towards the end of today. Just want to chuck out the opportunity there for anyone else to type any questions for our panel. And maybe I just might ask the panel if they have any other last minute thoughts or reflections or things you really want to say that you're passionate about for that invitation to do so. Kristen, was there anything else you wanted to add to today's discussion?
Yeah, I did want to add a few things, and one is that that I'm co-chair of the board of 2010, and Atari is a board director there as well, and we will be mapping the strategy against our strategy, and we'll also be planning about how we can actually implement that strategy And, you know, if we're going to create a community of practice, let's do so. Perhaps we can share. I can start off by, you know, sharing some of the ways in which we might think about doing that. It'll take us a little while probably to get that together, because I'll have to consult with staff to get them on board, but that won't be a problem. And yeah, so I you know, it would be really great to hear from anyone else online who is part of an organisation who would like to do a similar kind of thing. It often takes additional work hours to do this, perhaps outside of your normal duties. It's great if you can integrate it into those duties, but I would really strongly encourage people to try and do a similar thing. And it would be great if we could get back to the Alliance so they can have an understanding of how that's tracking. And I'm sure we'll have a conversation another time, Sally, about evaluating.
Awesome, thank you. Atari, any other last thoughts or reflections?
So, yeah, just to concur with Christian and also to put the call out to those who are listening to think about in your role and your organisation what it is that you guys can do and start somewhere. I think sometimes it's overwhelming because it's such a big issue and it's a hard issue, but certainly, you know, the community of practice there is a community of practice emerging, and I think the Alliance are a great facilitator of that community. And I think if we can share what is working and what isn't working, you don't have to reinvent the wheel. There's some fantastic initiatives happening around the country, and I'd encourage those who are online, if you're doing something great, to let us know. Or I just see there's an organisation plug right there from VAC and others. So certainly share what you're doing in your work individually and as organisations, and support each other so that you can kind of lighten the load and don't feel the need to reinvent the wheel.
Yeah, awesome. Thank you, Atari. Jude, do you have any last minute reflections or thoughts?
A little bit along the lines of Atari, there are a lot of great resources out there, so make use of them. I mean, the internet's a fantastic tool, and yes, we don't want to reinvent the wheel. But I guess my other plea would be, let's think about LGBTI lives across the lifespan. I mean, it's easy sometimes to feel that the emphasis is on younger folk only, and yet there are people along the whole age spectrum, and I think there are special considerations for older LGBTI members. And we as a community, and also members of service provision agencies, we need to educate ourselves about some of the history to understand why we're at the state where we are, and why maybe an 84-year-old person is not going to readily come out to you. And I think that's our responsibility. We can't put that education on those clients.
Yeah, awesome. Thank you so much, Jude. Thank you for everyone for joining us. And I think I just really want to echo what each of the panel members said about the benefit of sharing our wisdom and knowledge and skills and experience with each other, and for us as a community to really open to hearing and receiving that knowledge from others in our community. I think sometimes it's really easy to think that we're on top of it, we know it all, we've learned everything that there is to learn. But there's moments, even in my own work, when I've realised actually there's a lot that I still need to learn, and especially as our community is evolving, is adapting, it's still changing. So what we need to do as service providers in that space also needs to change. But again, just like the amazing resources out there, and really acknowledging that some of those across Australia, there's quite an unequal distribution of some of those programs and resources, really depending on state investment. And so for the states that do maybe have access to more resources and programs, to really think about how can you share those with other locations that might not have as many accessible to them as well. But I do think the more that we share collectively, the better community response we can have. So I just again wanted to thank the panel for joining me here today, Kristen Davies, Jude Comfort and Atari Metcalfe. Really appreciate your wisdom and knowledge and expertise in our LGBTI community. It's phenomenal. And I encourage, if anyone wants to touch base with the panel members, just please send us a message at the Alliance and we can touch base with them for you. And thank you very much for joining us. So thank you, everyone, and we'll end the meeting now. But please feel free to email me, sally.morris@lgbtihealth.org.au, and a recording of this webinar will be made available up on the Alliance website. It'll be up available the next couple of days. So please feel free to share this with your colleagues or other people in your networks who might be interested around a strategic response to LGBTI suicide and mental health. So great. Thank you very much.
Thanks, Sally.
Thanks so much, Sally.
Thank you.